Welcome to Sip with Summers, the podcast where we talk about sex, intimacy, and pleasure. Because someone has to, and let's be honest, it may as well be me. I'm your host, Jennifer Marie Summers, board certified sexologist, certified sex coach, menopause coach in training, and your favorite inappropriate friend with a microphone. Around here, we cover everything from why is my libido ghosting me to is it normal to fantasize about pizza during sex? Spoiler alert, yes. So grab a drink and let's get into the good stuff because pleasure is your birthright and awkward is my love language. Let's spill, sip, and say the things most people whisper. Welcome to the show. Today, we are diving into a topic that hits close to home for so many women: low desire and difficulty reaching orgasms in midlife. You know, when your brain says, let's get it on, but your body is actually like, I'd rather just get some sleep. To help us unpack all of this, I am joined by the amazing and fabulous Dr. Christine Hart-Kress. She's a seasoned healthcare leader with over 30 years' experience in women's healthcare. Dr. Kress served 27 years in the Air Force as a nurse practitioner and healthcare executive. She's also board certified as a Menopause Society Certified Practitioner, and she has advanced training in hormone prescribing, sexual health medicine, and the care of breast cancer survivors. Dr. Christine's passion lies in transforming high-quality access and care for women in midlife and menopause. She's the CEO and owner of a specialized telemedicine practice focused on comprehensive midlife and menopause care. She's also an active member of the National Association of Nurse Practitioners in Women's Health. She serves on the Advocacy Committee and the Conference Planning Committee for the joint NPWH, an International Society for the Study of Sexual Health in Women's virtual course. Dr. Christine has co-authored several key resources, including the NPWH's Scope of Practice and Health and Healthcare of Midlife Women Position Statements. She's received numerous accolades for her clinical excellence in leadership, including the Air Force Medical Service Advanced Practice Nurse of the Year and Tucson's Fabulous 50 Nurses Award. She's a published author in the field of women's health, and Dr. Christine has been featured on multiple podcasts and blogs, sharing her expertise and her insights. She also serves on two boards, the Bite Me Cancer Foundation and the Empower Scholarship Fund Board. Dr. Christine is also the co-host of the podcast, The Dusty Muffin, so she's definitely an expert at all things podcast. Dr. Christine, I'm so thrilled to have you here. Welcome to the show.
Yeah, thank you so much. I'm thrilled to be here as well. Thank you for having me.
Yes, you're so welcome. Dr. Christine, you've spent over 30 years in women's health. How have the conversations around libido and sexual health functions changed over that time?
I would say that we are now starting to talk about them. When I did my training, I graduated in 1999. I do not remember having a single course about sexual health. I don't remember talking about libido. We had one product on the market, Test, that we would prescribe if a woman would come in and say that she had decreased libido. But we were taught back then, prescribe it for a really short period of time because it increases your risk for heart disease. And it was, at the time, and I wish I could remember all the nuances of it, it was considered sort of risky business to prescribe the combination of estrogen with testosterone. And so to be honest, we didn't do it very much. I think that, in mainstream, like in academia, we're still really far behind. I will tell you that until I became a member of the International Society for the Study of Sexual Health in Women, that I did not even understand the clitoris myself.
Yeah, I mean, a lot of people don't understand the clitoris because we're not taught it and people don't even know where it is. I meet women at my parties that think the clitoris is inside their vagina. It's wild that even on a healthcare level, we're not learning these things.
Yeah, I mean, it just, It was never really a focus. And I think depending on where you practice, especially if you're practicing in a full scope women's health OBGYN clinic, the focus is on having babies and getting doctor surgery. And as a nurse practitioner, that's what we were doing, taking care of OB patients and generating surgical cases for the physician. And so we never talked about midlife health, and we definitely didn't talk about sexual health. And even when women would come in and say that they had decreased desire, we didn't have anything to offer them. Now, if they're, if they're outside of menopause. And so, really what we would do is we would refer to mental health and,
Wow.
and encourage couples counseling. And, our toolbox wasn't very deep. And we sure didn't know that there were any tools available to objectively validate that. Most of us just didn't really have a lot of experience. And I remember, if a woman came in and she was over 40, I either knew it was going to be a really short visit or it was going to be a super long visit. And I would get really frustrated, not because of the patient, but because I wasn't taught perimenopause. And if you didn't have hot flashes, I didn't really know what else to do for you. We would give vaginal estrogen, but I'll be honest, it was probably rather sparingly. Like I remember prescribing a lot of birth control pills. And so, I think it is fantastic now that we, obviously 20 plus years, right? 23 years since the Women's Health Initiative. And now there's this explosion of women getting loud because they want to be heard and they want answers and they're demanding care. And so, it was my own perimenopause experience that sort of convinced me, like, you don't know anything about midlife health and you don't have any providers that know in my circle. I didn't have anybody who could take care of me. So I'm like, all right, well, I don't know anything. I don't have anybody in my own healthcare system that knows enough to take care of me. And I just really became interested selfishly to fix myself.
I'm in school right now for menopause coaching, and I'm in a late reproductive age. So I'm not in menopause yet. But what I'm finding is a lot of my classmates are using themselves as their own case study because they haven't been able to get answers from providers. They haven't been able to use traditional, like birth control, let's say, to feel better. So a lot of women are looking for answers and desperate to feel better besides just suffering for 10 years.
Absolutely. I experiment on myself before I experiment on my patient. So I try everything. And when something's not working, I move on to the next thing so that I can provide at least some of my own personal experiences when I'm caring for patients. I've been doing midlife and menopause care now since almost 3 years, where that's all I've been doing. I've been taking care of menopausal patients, just not very well, apparently, for a really long time. I was prescribing before the WHI, and the only thing we would prescribe is Premarin and Provera. That was it. That was what we had on formulary. If there was anything else, nobody told us. Prempro, Premphase, a little bit of estradiol, and maybe some Premarin vaginal cream because Trace was considered too expensive. And so it was really, really limited. And so it's exciting now to have all of these options. But I think the conversation is open. And I think right now, clinicians are trying to get themselves educated. Sometimes it's a little scary because there's lots of places where you can get that education. And, I've been hearing just some horrific stories or seeing some horrific stories on some of the Facebook groups, like a patient who's taking 9 milligrams of oral estradiol, and 700 milligrams of progesterone.
Whoa.
And I haven't quite figured out if she actually has a clinician prescribing that for her or
Hmm.
if she is managing it with the medication she has on hand. And I'm like, this lady's she's gonna get a blood clot. She's gonna have a heart attack. Something bad is gonna happen. We don't prescribe that amount of medication. It's a little bit turning into the wild, wild west. And that's a provider that's actually prescribing it. that provider needs to be turned into the board because that is malpractice.
Oh my gosh. So, I mean, there's options like testosterone, Addyi, and Vyleesi. Can you walk us through how those work and who they're meant for?
Yeah, absolutely. So testosterone starts declining around age 30 for women. It's very slow, it's very gradual. If we were to graph it out, it just looks like this little baby, line, like a baby roller coaster. Some women feel it, some women don't. Most women will feel it when it hits rock bottom, but it can take 20 plus years between being 30 and menopause if the average age of menopause is 51 for women really to appreciate their testosterone. And what most people think is that it's only about sex. So, sexual desire, arousal, orgasm, sexual satisfaction. But there's a lot of other benefits of having testosterone. It's good for your heart. It's your energizing hormone. So, women who have a lot of fatigue benefit from having that testosterone replaced. It's good for, you need it to develop muscle mass, right? And you need muscle mass for metabolism. And so many women are struggling with weight loss. It's not FDA approved to use it that way, but it is beneficial and also good for your bones. But it's a neuroendocrine hormone. So while it gets you in the mood, it also plays a big role in your mood and can be really helpful with anxiety, depression, rage, or even just, a lot of women will say, I have this really great life, but I feel like the spark is not there. I don't understand. I have a perfect career, a perfect family, and I don't like any of it. And I don't understand how I could have this great life and not really care about it. And so, it does work on your brain. And so testosterone, when we're prescribing testosterone, we like your testosterone to be somewhere between 55 and 110. Most of the time, when I am drawing to serum testosterone levels, I am seeing to serum testosterone levels like in the 20s, really, really low. And you would think it's the 55-year-old who has a testosterone of like 10 because she's super menopausal at this point, right? A few years into postmenopause. But even I have some patients that are like 40s and their testosterone is already rock bottom and they sure do feel it. And so I like to use Testim gel. The generic is testosterone gel, and we use 5 milligrams per day. You rub about a pea-sized amount on your deltoid. If you do it at night, anecdotally, women say that it helps them sleep like a baby or a teenage boy. They say, I get the best sleep when I do it at night, just like a teenage boy, which makes sense, right?
Yes,
I
totally.
I think a lot of women don't realize that you have, depending on where you're reading, 4 to 5 times more testosterone premenopausally than you do estrogen. So it's a really important hormone that we've sort of, we gendered to be a sex hormone and we associate to be men. Men actually, by ratio, have less testosterone than women do. We actually have more by ratio of that. I like using what we can get from the pharmacy, although there's no FDA approved testosterone for women in the United States. We use what we use for men off label and a little small tube, which would fill up a 5 cc syringe, lasts a woman 10 days, where that's a daily dose for a man. And it takes a good 6 months for those levels to go back up. It can take a good 6 months for women to have any, good effects. Like they want to have sex, thinking about sex. And then, there's a percentage of women that it does not work and they don't have any change in their sexual desire. And that's where we really then need to look at other things, relationships, stressors, lifestyle. I do check levels to make sure those levels are climbing. And, I think women think that all of a sudden they're going to have this spontaneous combustion of desire and they're going to want to be humping everything. And, lust is what gets us into sexual relationships, right? And love is what keeps us there. And so it's not going to be your 20-year-old horny jackrabbit type of working. That, I mean, it's not a miracle worker. You got to really like the person you're going to have sex with on top of that, right? And people physically change, and, the way you respond to people changes. So I think you have to have realistic expectations in terms of that. The other thing that we use is something called Vyleesi. It comes like in an auto injector, just like what we use for the weight loss medications. And you can use one every 24 hours, no more than 4 in a month. And you use it about 45 minutes before planned intercourse. So you have to plan for it. It can increase orgasm, increase excitatory response. It increases neurotransmitters that cause sexual excitement. It increases that activity in the brain. They're not exactly sure the mechanism of action, but women do like it. It's not often covered by insurance. You can get it through a pharmacy called Blink RX, and you can get 4 pens for $99. So that's pretty reasonable for intercourse. The testosterone gel, I'm going to go back to that.
Yeah,
Most
please.
insurance do not cover testosterone gel. Their TRICARE covers it if you're postmenopausal, but won't cover it if you're perimenopausal. There are some Cigna and Aetna that will cover it. Blue Cross Blue Shield, United Healthcare do not cover it at all. But, used in the Good RX app, you can get a 300-day supply for anywhere from $77 to $106. And I have seen it on the Good RX app be that wide in pricing. CVS is the most affordable. So I always tell people once a year, go to CVS unless you want to pay up to $300 for it. I'm all about where, there's other ways you can spend your money than on testosterone gel. Go to CVS once a year and get that. You can use compounded creams. Compounded creams are about $75 for 3 months, and you can use compounded. Some women like them because they come in the click top, whereas the testosterone gel is really a little bit of a guessing game. Like, how many days have I been using this tube? Is it 7? Is it 9? Is it 12? I find most women underdose instead of overdose on their testosterone. I'm like, how long is that tube taking? About 30 days. So I'm like, it's never going to work if you can write on it, keep track of it, figure out a way, as long as you're not using a tube a day. And I don't like people to use a tube any shorter than 8 days because we want to minimize side effects. Women will do well, but some women want the compounded. It's more expensive. You definitely can do that. Some women feel it's a little bit easier with dosing.
Now, that actually leads me to a viewer question. So I have this link on my website where people can ask anything anonymously. And I felt like this question was really pertinent to our conversation today. They said men have blue chews, Viagra, et cetera, to help them get and stay hard. Why can't somebody make something for women to help with arousal? Fully recognizing the differences, of course, between the sexual organs. So would you compare this Vyleesi and testosterone to that, like Viagra for women essentially, or is there something else that might work?
The Vyleesi and Addyi is another medication that we use. It's a once daily pill. Insurance does cover that pretty well. It improves desire and satisfying sexual events. We do use sildenafil in women. We can use it topically. We can also use it as an oral tablet. You've got to have a really clean cardiovascular bill of health. We want your cholesterol to be good, which I know is not really fair, but we don't usually use it in women. It's very rare. The cream is all fine to use. If women have blunted orgasm, one of the most important things is to have a proper exam by someone who's trained to be able to evaluate the clitoris, because a lot of people don't realize that there is a hood over that clitoris. And if that hood gets adhesion, it's supposed to be able to be retracted back, just like the foreskin of the penis. But some women, we develop adhesions, and that will really blunt orgasm. And so those adhesions have to be released, so to speak, by someone who's trained to do that. The other thing, so having a good exam, making sure that you don't have vaginal dryness, making sure you don't have lichen sclerosis, which is an inflammatory disorder. It's an inflammation of the skin of the vulva that gets really paper thin. It becomes very brittle. It also is very itchy. And so ruling out that you have other things that are contributing are always the first thing that we do. I tend to try testosterone first and then add things like Addyi and Vyleesi. I mean, you can use the Vyleesi, with the testosterone. You can use the Addyi with the testosterone as well. And so, one thing at a time.
And what about vaginal estrogen or DHEA? Are those just for dryness or can they also help with sexual desire and function?
I mean, if you have a dry vagina, you're not going to feel like having sex, right? Because you're going to
Definitely.
send a message to your brain that that's painful. When you are premenopausal, the vagina is well estrogenized. The tissue is plump. It has good blood flow. It allows good lubrication. It's very elastic and it gives, right?
Mhm.
The tissue is very supple, especially at the what we call the fourchette or the entrance of the vagina, because without estrogen, it becomes dry, painful. You can have a ton of bladder symptoms. That fourchette or that opening of the vagina is like it gets a lot of like little paper cut tears, little micro tears that are really, really, really painful. And so, most women over the age of 40 or other times in their life, if they're on birth control pills, you're going to have genitourinary syndrome of menopause. Pregnant is a low estrogen state. You will also have the same symptoms. And then breastfeeding. So there are other times that you can use vaginal estrogen besides perimenopause and menopause. But genitourinary syndrome of menopause, makes sex really uncomfortable. And you have to, even though the systemic therapies like oral patch, gels, sprays, ring, a fem ring, which are considered systemic therapies, they help with your hot flashes. But unfortunately, if you already have the symptoms, they're not really going to help get rid of it or estrogenize you all the way. And so the vulva, which is everything on the outside, and the vagina, which is the inside, and the bladder tissue, which you've got tons of bladder tissue around the opening of the vagina, need to see estrogen. If you have other bladder issues, getting up at night, stress, incontinence, urinary frequency, the urethra needs to see it. But the clitoris also needs to see it because that tissue, if it's not plump with good blood flow and healthy tissue, it's going to be painful. For some women, it can be really painful to have an orgasm. It
Mhm.
just takes a really long time because there's not a lot of sensitivity, because there's not a lot of good estrogen and good blood flow. So a little bit of vaginal estrogen, about the pea-sized amount on your finger, to the clitoris, the urethra, the vestibule, and the fourchette is awesome for genitourinary syndrome of menopause. And then a gram inside the vagina. I always do loading doses with my patients, which is 1 gram every day for 2 weeks until you get to 2 weeks, or if you're going to throw the whole thing in the garbage, then stop then and then switch to twice weekly. But on the outside, every day, as many days as you can remember. If you forget it here and there, it's not going to be an issue. And then if that vaginal estrogen doesn't work, then you could use something called Interosa, which is DHEA. It's also known as perasterone. It breaks down into androgens like testosterone. It breaks down into estrogen. It's considered non-hormonal. It's a little oily. You use it every day. So some women, that's like a little bit messy. The other thing that you can do is a supplement, a DHEA 5 milligram dissolvable tablet. Pop that in the vagina. I call it poor man's DHEA because Interosa is not well covered by insurance. And you can do that every day to get those androgens. Often, especially with women who have difficulty with orgasm, they need to see some testosterone. And so we can also compound a cream of estradiol and testosterone to place on the clitoris and on the labia, the vestibule, and at the introitus, which works really well. I think there's definitely a role with decreased desire if you do not, and especially if you're dry, to fix that. You got to fix your vulva. You got to fix your vagina. Otherwise, if it's painful, that's going to be miserable. You can use a daily moisturizer. I have a couple of them that I like. This one is by Rosebud. It's called Honor. I like another one by Intimate Rose called Enchanted Rose Balm. I think is
Yes.
the name.
Yeah, I have that stuff. I love
Do
it.
you?
Yeah, I have that in my
Yeah.
store now. I love Intimate Rose. They're a great company to work with. And their
They,
dilators right there behind
oh,
you.
there they are. Yeah. But I mean, they're great. Like, it's good for maintenance. It's like
Mhm.
putting chapstick on your lips or lotion on your legs. They're not going to fix the problem, but they're another supportive tool. And then lubricant always for penetration. You need lubricant to help with friction. Over 40, lube is just part of the threesome. You have to use it. Lube up your partner or lube up your toy, and just a little bit at the fourchette, at the opening of the vagina. And be careful, because if you get a lot of lubricant around the clitoris, especially if you're masturbating self-pleasure, it gets kind of lost in the sauce, and there's just so much lubricant that it does decrease some of the stimulation for a lot of women. But those are the things that I recommend for my patients. And the other thing is, if you've been having sex the same way with the same person for 30 years, it's time to spice things up, my friends.
Yeah. That's where I come in.
That's where you come in. Only 10% of women will have an orgasm with penile penetration. And I don't think that is a known fact. 90% of women will have an orgasm with either self-pleasure or with a vibrator. 10%. Like, this whole G spot, hit the G spot, it's really it's not exactly a place. I mean, it's the bulbs of the clitoris swelling. And I think so many women think that they're broken because maybe they've never had an orgasm with penile penetration, or maybe it stopped working, but it's actually quite rare.
I recently had a client that came to me for some sex coaching, and she was struggling because she felt like there was something wrong with her because she was unable to orgasm from her partner's penis. And she desperately wanted to be able to do what they do in the movies where they both orgasm at the same time. And it's this beautiful moment. And, of course, like I worked with her, gave her some action steps, but ultimately it's that educational part of like, what you see in the movies is not real life. And maybe it can happen occasionally, but this is not something that every time you have sex with a partner as a penis, you're going to be having mind blowing orgasms from a penis in your vagina at the same time.
Right. And, probably more men know that than women. I think women think that it's about penile but penetration. But I think, too, that people think the clitoris is just the bulb here. And this is actually 10% of the structure here at the top. But the clitoris, I'll pull this out.
Yes.
There she is, right? I mean, I
She's
know
so
you live
pretty.
there. Yeah, she is pretty. And these are the legs, or they're called the cura. They run along the labia majora, underneath the labia minora. And then the bulbs actually run down the opening of the vagina. And during intercourse, they swell, right? During excitation, they do swell, and they kind of tighten around the opening, which is why with penetration, you get it's hitting those bulbs, and they do get large, they do expand up to 9 to 12 centimeters. I mean, that's pretty big. Who knew that there was all this under here? And so just rubbing at the clitoris, you're missing a lot of at the tip, you're missing a lot of good sensory points. So there's over 9,000 nerve endings in the clitoris. And rubbing underneath the labia minora, rubbing around the opening of the vestibule, those where those bulbs are. And if you kind of rock your finger back and forth, you can feel those. And so don't stop just at the top. That's why a lot of women do really well if they're having oral sex or if they are self-pleasuring with their finger, with also having that vaginal penetration, because you're using your whole nerve endings, you're using your whole clitoris. Don't forget that it's not just about the little button at the top, it's the whole thing.
It's the whole
Um,
thing.
when you were asking about how things have changed, they actually left out the clitoris in medical textbooks. It wasn't in there until the 1990s. And it was mapped by Dr. Helen O'Connell in Australia. She was the first person to say, hey, the clitoris, like, first of all, it's not just the button, it actually is bigger than what people think and quite dynamic. And just like the penis, they come in different sizes and shapes, just like your labia come in different sizes and shape. Every clitoris is unique, but it's the only organ in our body that is dedicated to pleasure. So pleasure the hell out of her.
If you want to get on my nerves, get on one of those nerves, please.
You know what I read recently, which I thought was really interesting? That it grows throughout adulthood. And actually, some studies show it can grow 20 to 30% in menopause. So that's why you literally can have the best sex of your life. I mean, you don't have to worry about getting pregnant, which is really awesome. But your clitoris actually grows, which means that pleasure organ with 9,000 nerve endings is just waiting for you to take advantage of her.
Yeah.
So
Do it. I mean, what is it? Like 87% of women need clitoris stimulation in order to orgasm from penetration. And at my parties, I always talk about how the clitoris and the penis are the same tissue. They're organized differently. And it's so important to pay attention to that little man in the boat.
Mm-hmm. Exactly. The bulbs are just like the dorsal shaft, the underside of the penis, which is what, you get all the blood flow. That's what promotes erection.
Mm-hmm.
So absolutely. So that, that peni, putting something in the vagina at the same time is going to stimulate. Or I think it was your Rita, right? About, how to get it up, or I forget how you phrased it, but that same concept of men, of helping them be hard, helping them be erect. It's knowing that you have other pieces of it that you have to stimulate as well.
Yes. Yeah. And it needs time. I mean, women need, what is it? 80% of women need 12 to 20 minutes of foreplay before they're ready for a penis. And then, like you said, it's what, like 10 to 20% are even going to orgasm from the penis when they get it.
And during this time, like in the perimenopause, menopause, I tell women, be ridiculously selfish, because it's not just about the hormones. It's not about optimizing your minerals and vitamins and taking care of your metabolic health, but sexual health is self-care. And so you don't need anybody but yourself. There's tons of great products on the market, vibrators, and it's a time to explore. Like, there's no shame in exploration and figuring out what you really like. And it doesn't always need to have a partner involved, because maybe what you like doing that alone.
Absolutely. Yeah. I have clients that have
fine.
fantasies that they're like, I would never want to do this with a partner, but I think about it a lot. And I'm like, great, get a vibrator and put on a blindfold and think about it. Like, you don't have to do everything. But I also think about shifting this focus from the clitoris being the bonus to being the main event. And so really giving that focus to the clitoris before any type of penetrative sex happens. I'm curious, from a medical perspective, how do you feel that toys or clitoral stimulators can benefit women and help them reconnect with their bodies?
There are actually some studies about the fact that there are actually some vibrators on the market that actually increase blood flow enough to restore, to help with reduced genitourinary syndrome of menopause. And I think it is a way to connect with your own body. And I think if you're having difficulty with orgasm, that is a lot of pressure for women, right? To perform for their partner. And the worst thing you can do is fake an orgasm, because then the guy actually thinks he's good. and maybe it's not good, right? And so that's the worst thing. And so using a vibrator is, a fantastic way to reconnect with your body. But another, and not a vibrator, a clitoral stimulator, and just providing that clitoral stimulation and sending those messages back to your brain in regards to pleasure and being able to do it where you don't have the pressure of someone else. And so if you don't have an orgasm, then you're disappointing yourself, but it's not, I don't know, a couple's event or a public event. And you don't have to pretend that you had an orgasm when you really didn't. And I think that sometimes when you have intercourse, you may not have an orgasm. And it doesn't need to always be about having the orgasm. It's about having that connection with someone else. And so if it was a good time, then, I think, being okay with, okay, I didn't have an orgasm. I'm not broken, but I had a really good time and I want to do that again. And that's when we know that some of, especially if we're using testosterone, that's when we know things are starting to work. If you're like, that was a good time, I want to do that again. And so I think that's important for women. I think one of the things, like to kind of put this whole thing in context, is to really understand, for women to understand sexual desire. Patients use different terms. They use sex drive, libido, horniness when they talk about sexual desire. And sexual desire means that the patient has a motivation to engage in sexually with their self or with a partner. It is manifested usually by some type of spontaneous thoughts, fantasies,
Mm.
tensions of intimacy, or engagement in sexual activity. And, it's important to distinguish between responsive and spontaneous desire. Responsive is response to your partner's stimuli, like they nibble on your ear or on your neck, and you're like, ooh, I like the way that feels. Versus spontaneous desire is seeing the hot guy walking down the street and you're like, I want to jump those bones, or you have this sudden thought, or you have the fantasy, and 85% of women value sexual enjoyment. And I always tell clinicians 44% experience some type of sexual problem and 90% want their provider to discuss it. And I think that's the hard thing, is that maybe you're having a sex life that doesn't fulfill you and you don't have anybody that you can talk to, or your provider says stupid shit like, tell your husband to clean the kitchen, or, sometimes that happens when you get older. You just don't want to have sex like you used to. And so, finding someone who can have that conversation, I think, is really important. The certified menopause practitioners, we have that training. I think also the International Study of Sexual Health in Women, we call it ISHWISH. They also have a provider directory of people that can help you from the medication. And then, Jennifer, people, coaches, sex coaches, people that can talk about sex in a way that is not shaming or blaming, and can give you
Mm.
ideas to make you feel confident in your decisions. So I think it really does take whole village to be able to get where you can just have free and expressive sex in the way that makes you feel fulfilled as a woman.
Amen. I could not have said that better. And I love the responsive and the spontaneous. I learned about that when I read Come As You Are by
Mhm.
Emily Nagoski. And it was so illuminating because even for myself, I work in this field, but I've had my own issues and concerns over the years. And it's just really nice to feel like you're not broken and things are normal. Thanks for bringing that up for our listeners, Dr. Christine. That's awesome.
You're welcome.
So we know desire is not physical, right? It's related to all sorts of different things, energy, mental, like how we feel about our partner. What impact, though, do you think that stress, sleep, and relationship dynamics have on the libido?
I mean, I think it's all connected, right? I mean, most women in perimenopause, what I hear from the vast majority of women is, I'm waking up between 1 and 3 in the morning. Sometimes I can fall back asleep. Sometimes I'm up for 2 hours. Sometimes I'm up for the day. That is going to drain on your energy. I think the things that we used to be able to do like party all night and go to class with 2 hours of sleep or go to work. Maybe if you did a breathalyzer back then, you wouldn't have been legal to work, but you went, and then kids, babies and teenagers, and you've been able to get through and you've had enough resilience to be able to adjust to those deviations in your sleep. But, when your hormones are in a giant roller coaster, which is what they are in perimenopause, we call it reverse puberty, women can't sustain for very long. And so then that starts to cause mood issues, anxiety, fatigue, perimenopausal rage, when you react to your partner, your children in a way that you regret after it comes out of your mouth, but you're so mad that you just own it and you're like righteous and you're like, I was right, but it was really stupid. Like it was really dumb. And then, over time, that stress is going to increase your cortisol. It's going to increase your inflammation. And then it's going to start to impact your energy. And, it's no wonder you don't have any interest in having sexual intercourse. You need to be rested. You need to have good nutrition. You need to have exercise. You need to have an outlet to be selfish, because during this time of your life, frankly, you don't know if you're coming or going in perimenopause. And every day is like a new symptom, a new challenge, a new experience. And you're like, holy shit, I'm falling apart. I'm getting old. No, your hormones are just giving you a little run for your money, but we can get you through that. And so I think some of it is patience. I think it's working one thing at a time. And I know when patients come to me, I work on sleep and mood first, always. Because if you're not sleeping, you have a shitty mood, none of these hormones are going to work because your cortisol is going to be up high. You're going to be inflamed. So I work on progesterone first, and then I work on estrogen, making your bones a little less achy, making the annoyance, whether it's the heart palpitation, the itchy ears, the burning tongue, or the burning feet, or the hot flashes. Like, we take care of that. And we also I take care of the vagina really close to the very beginning. Most of the time, the first visit, I am onboarding, because it can take 6 to 8 weeks to fix that genital urinary syndrome of menopause. And then we work on libido. So it's typically the last thing I work on, because when I've got progesterone on board, I layer in some estrogen along the way. I fix your foundation, your vitamin D, your B12, your ferritin. Then when it comes time to add the testosterone, that's where the magic happens and the veil lifts. I only have one patient on Vyleesi, and the rest of my patients who come to me, and I would say 99% of them come to me with decreased libido, do just fine on testosterone when everything else is optimized. So it's probably a long answer, and I probably answered 4 questions in one. Sorry.
No, that was perfect. That was great. What's one mindset shift that you've seen change everything for women's desire and confidence besides the medication?
I would, I think being okay with putting themselves first, I think has been very powerful. And, it usually presents itself in initially things like, I'm going to get my protein in, I'm going to get my exercise in, I'm going to do a girls' weekend, I'm going to buy a clitoris stimulator or a vibrator, I'm going to get myself some lube that doesn't make me itchy. And then I think women they just become so empowered. The more they feel better and they take control, and, they don't put up with the bullshit of being gaslit, and they just don't put up with feeling like crap.
That's a great way to put it. Yeah. Now, I did want to jump back because I was curious about, we talked about hormone therapy earlier. I meet a lot of women who are afraid of hormone therapy just because of what they heard in the past about it causing cancer. And, one thing that has always been really interesting to me is if estrogen caused cancer, there'd be a lot of women in their 20s and 30s with cancer because that's when the estrogen is the highest, right?
Correct.
So, what are some myths around that you wish would just disappear for good?
That estrogen is dangerous. The estradiol in the Women's Health Initiative study The women who did not have a uterus and were on estrogen only, estradiol only, they had a 23% decreased risk of breast cancer. It is the synthetic progestogens, like what's in birth control pills, Provera, medroxyprogesterone is the other name for it. Norethindrone acetate or agestin is another component. It was the synthetic progestins in the WHI that had a statistically insignificant risk of breast cancer. And what was that risk? It was 4 women out of 1,000 was baseline that went up to 5 women out of 1,000. It's a 0.9% increased risk of developing breast cancer. The New York Times published it as a 25% risk because they were looking at relative risk versus absolute risk. And so absolute risk is the actual probability that you're going to get it, which was 0.9%. And so even, women who developed breast, they had women in that WHI, half of the women were on no hormones at all. And when they compared the women on hormones to the women not on hormones that were taking the synthetic progestins and estradiol, the women on hormones had a 30% reduced risk of, how do I phrase that? 30% reduction in mortality. They were 30% less likely to die. The tumors were easily contained. They didn't metastasize and they were curable. And so, estrogen and breast cancer, that is a myth. But, I have a few patients, even in their 50s, they've never had a mammogram. And there is no clinician out there that is reputable that will prescribe hormone therapy without annual mammogram screenings. Because if you have a tumor in your breast that needs estrogen or progesterone to grow, it's going to grow. And so it's not going to cause the cancer. The tumor, the cell activity was already there. It's just like dropping a little bit of fertilizer on it. And so we want to find that sooner. We want to know what you look like baseline, and then we want to find it as soon as possible. And, so it's really important to get those screenings. But I think the WHI, they have walked back every assertion now over a 19-year study. And, they walked it all back. And it's such a travesty that hormone therapy, was taken away from women. The boomers are pissed. I tell women it's never too late to have the conversation, but your complexities of whatever medical conditions you have developed, which have been from not being on hormone therapy, may make your risk when you go on hormone therapy greater than a woman who's been started in hormone therapy within 10 years. But I think women have the right to choose. I think as providers, we have do no harm, right? So someone who just had a stroke or a heart attack, we're not going to give hormone therapy to. We can give you vaginal estrogen. But someone who had a history of a blood clot 20 years ago from being on birth control pills, for example, can choose to go on hormone therapy on a method that doesn't increase those risks. And so I think women, autonomy over your body, I think women have the right to have those conversations and to make those decisions. And so it's, what we call shared decision making.
And transdermal is best in those cases, right? Because it doesn't go through the liver.
Correct. Yep. It doesn't increase clotting factors and doesn't increase your risk of having a blood clot. The whole purpose of the WHI was to see if we could use hormone therapy as primary prevention. But the problem of heart disease, and the problem is that the women that they recruited, their average age was 63. They had been years and years without hormone therapy, which we know without hormone therapy, women will develop diabetes. They can't break down bad cholesterol. They can't make good cholesterol. Those women were obese. They were smokers. They had high blood pressure. We know without estrogen, your vessels get tight. That's why we tend to see women in their 60s around 4 to 5 medications by the time they're 65. And it's usually something for their blood pressure, something for their cholesterol, something for their mood. Don't forget some sleep. And then we start adding in bone medication. That's how powerful are replacing the estradiol and progesterone and testosterone. That's how important it is in keeping us healthy, because most women don't develop those things when they have good levels of their hormones. As soon as they go through perimenopause, we start seeing changes in their labs and these other chronic conditions develop.
Now, for our listeners, how do they know when it's the right time to see somebody for menopause concerns? Is it that their period is changing? Is it they're feeling bad? Is it something else?
Yeah, I mean, perimenopause, the cardinal sign, tends to be some type of change in your periods. Usually they get heavier, closer together, more clotty, more crampy. But, that I have started women on progesterone during those times just to help get a little bit of reprieve from the amount of blood flow from having heavy cycles for women. But there's a menopause rating scale. There is a green climacteric score where, the green climacteric score is, how many questions is on that thing? Now I can't remember. 23, I think, questions. And you rate your symptoms from 1 to 4. Anything more than a 15, it means that you're deficient in, it really is measuring estrogen, but you're deficient in hormones and can have that conversation. I would say that anytime you start developing multiple symptoms that weren't otherwise there, and now all of a sudden you're in your even your 30s, because although average age of menopause is 51, and 90% of women stop their period between 45 and 55. Perimenopause begins 10 years before that. So 35, 30 is not unusual, because 1% of women will go through menopause before age 40. 5% of women will go through early menopause before the age of 45. So when you back that up, if you're in your 30s and you're like, I'm not sleeping, I'm having some hot flashes, I'm having some joint pain, carpal tunnel, plantar fasciitis, hip pain, ringing in my ears, heart palpitations, then, those are symptoms of perimenopause. And, when you go to your primary care provider or your OBGYN, they may offer you birth control pills. They'll probably offer you an antidepressant. And, I think, unfortunately, a lot of providers, if you're not in the menopause window, don't find there be value to treat those hormones. I give, my youngest patient I have right now is 29. So you're never too young. You're never too old for the conversation, and you know your body. And so if your provider's not listening to you, that's not the right provider for you. What I find is that 5 years ago, women started doing the ologist walk. They would go to the rheumatologist for their joint pain. They'd be an ENT for the ringing in their ears. Don't forget the $1 million cardiology workup and all the time in physical therapy, because no one could connect all the dots to realize, wow, that's hormones. And so we send women, I mean, you probably know people, they got a million specialists they go to. They're on a ton of meds and they still feel
Yeah.
like crap. It's hormones.
Yeah.
And then if we give you when we start giving you back some of these hormones and those other things are still lingering, then it's probably time to go to a specialist, because it may not be hormones. But I would say 90% of the time, it takes care of 80% of the problems.
Wow. That's amazing. I did have one more question that one of my friends asked me to ask you when I
Yeah.
was like, I'm interviewing a menopause doctor. She's like, "Yeah, okay." So she said, is there an over the counter product that will actually help me with the change in my metabolism and the magical 15 pounds that I've gained with no change in my lifestyle or exercise habits? Or is there something different I need to do?
There is no magic. There is no magic over the counter that will help you with that. Obviously, there are foods that you'll hear a lot of the holistic nutritionists talk about, foods that can support the glucagon like peptide, which is a hormone that your stomach secretes. I think that might work. You have to extend more energy than calories that you consume. The weight gain in perimenopause and menopause is a real deal. Average weight is about 15 pounds, and it feels like it comes out of nowhere. The way we ate before our hormones started shifting, what we eat, how we exercise is not going to work the same way. You're not going to have the same benefits. Most women don't have the same results of the old things that they did. So all that cardio is going to increase your cortisol, increase your inflammation. We really want you doing zone 2 training. Zone 2, your heart rate is 181 minus your age is where your zone 2 heart rate should be. Lift, because if you don't have muscle, you will not burn fat. Your metabolism will be downshifted. One of the things that make this thing so difficult is that when your estrogen is low, your hunger hormone called ghrelin is up, which is why you feel ravenous, and your satiety hormone, leptin, is down. You can actually do a blood test for leptin. I actually just did one on a patient. And I was like, oh, it's low. And she gained 30 pounds and she's really struggling to get the weight off. I like GLPs. I don't find them, it's not cheating. It's if you just like when your thyroid goes kaput, you replace it with thyroid hormone. You don't even think about it. When your pancreas goes kaput and you have developed diabetes, you give yourself insulin, a hormone. You don't think about it. Ovaries, same thing. The stomach, the glucagon-like peptide, women who struggle with weight chronically, but even women in menopause, they need that hormone replaced. And so the GLP-1s have a really, work really well, especially when you're on hormone therapy together synergistically to promote weight loss. There's some other peptides. I don't know if you say it's Semelarin or Samoralin. It helps burn the fat. You have to get it through a provider. It's another peptide, works really well for sleep, by the by, that you can augment with that. But I'm a big fan of the GLPs because I think that we know that having that added weight increases your risk of chronic conditions. And my goal is to help women live the next 40 years the way they want to live it. When we're working with hormone therapy, I don't want women to break a bone. Estrogen is the only thing that keeps your bones where they need to be. We know that being on estrogen therapy reduces your risk of Alzheimer's by about 30%. We know that for every hot flash you have, the brain lights up under MRI, and those are mini strokes that increase your risk of Alzheimer's and cognitive decline. My goal is to help women live a life where they don't have to be dependent on their families. They don't end up in a nursing home with Alzheimer's or dementia. I mean, it still may happen even on hormone therapy. It's just you're reducing those risks. Think about the one woman in your life that you love the most, that you're like, please don't let me age like that. That's what I strive to help women do.
I'm thinking of that woman now. Yeah. But preventative medicine is the best. I'm on GLP-1. I've lost 27 pounds. I was, no diabetes or anything like that before, but I'm protecting myself. And I see hormones as a way of doing that too for later life, for like osteopenia or like you said, dementia. So Dr.
Yeah.
Christine, thank you so much. Any closing remarks before we wrap this up?
I think that this is an exciting time in our lives. And, our menopause is not our mother's menopause. Some of the women in their late 60s, early 70s are like, oh, I'm all done with that. I don't know about you girls now. It was no big deal. Well, it is a big deal because of the long-term consequences. And so I think, finding someone that can help support you is really, really important. And if you can find it in your insurance-based system, that is fantastic. There are those gems out there that have learned hormone therapy and have stayed in the healthcare system. But if you can't find that in your system, don't let that be your obstacle.
Thank you so much. You're so awesome. And I know our listeners are going to love hearing from you, Dr. Christine. And I'll have all your info in the show notes for everybody to check you out and follow you.
Thank you so much. It was great being here.
And that's a wrap on this episode of Sip with Summers, where we laughed, learned, and probably said clitoris more times than your high school health teacher ever did. If you liked what you heard, be a gem and leave a review, share it with your favorite group chat, or send it to that friend who really needs to hear this. You know the one. For more tips, tools, and slightly inappropriate jokes, follow me on social or head to summersoflove.com. Until next time, stay curious, stay turned on, and as always, keep sipping.